I want to raise a controversial issue. Ethics research has just come on board, and I think we need also to think about translation. If we look at those two cases, problems have been identified. Who is going to advocate for the changes? Other than saying, we have found this, you will lament over it. So who is going to take the responsibility of influencing policy? I would think that the researchers, the scientists, those who are in high places would start from there, but we start with translating our findings into a form that can influence policy. Maybe others can start from there. Thank you very much.
If both of you could answer that, if you just take the microphone there. Thanks.
Yes, all of us have a joint responsibility to make change happen. And even writing up these case studies and discussing them is one start. And the other effort is to the Indian Council of Medical Research guidelines for human subjects researchers undergoing change, and to work with them, which is what many of us are trying to do, to work with them in their recognition or the way they define vulnerability, and all of that is part of the translation effort that you're talking about, which we are trying to do. But guidelines are one thing, and as has been pointed out constantly from the morning, the law and the regulations are already in place. So guidelines can only push to some extent. In some contexts, there are laws which are not being implemented, but in the Indian context, there are laws which are being implemented which are problematic. That is the problem.
With respect to the case study that I presented, it's a lifestyle. I mean, India is having a real rise in non-communicable diseases as such, and the case, like the case I presented, the possible reason why it was excluded was just that the ethical guidelines of the country where it's been done consider it a special group, and the researchers were not. They believe that being a special group, you can exclude them. So I think it's very important that the ethics committees and this global forum should really take effort to plan and to have policies and recommendations which strongly advocate on excluding pregnant women, especially when the risk by being part of the trial is very minimal. So I think the granting funding agency at the first level should see that the proposals that come is actually not excluding the special group just because it's a special group. And then I think the Institutional Ethics Committee do have a strong role to ask for a justification.
Joe at the back, and then Annette.
Thanks, and thank you both for those really interesting cases. I wanted to flag an issue that was mentioned in Elizabeth's presentation, but I would imagine that either of you might be able to speak to it. And the issue is this, that in contexts where there is a certain amount of suspicion of research, if we conduct research with pregnant women, and there are some adverse events which may not be caused by participation in research at all, but nevertheless happen to women who are enrolled in research. There may be a perception among people in the community that those events were caused by the research participation. And so this is a danger then that because there's distrust of research, we've tried out doing research with pregnant women, some terrible thing happened, and now we're not going to allow it anymore. Are there strategies that you can suggest for sort of preemptively avoiding those sorts of mistakes?
Yeah, actually, the whole I mean, in the setting, in Kerala setting, I would say that if you look into the West, when somebody becomes pregnant, if they have a high risk, they're overweight or obese, naturally a lifestyle intervention, I mean, lifestyle advice is given. But if you look into the Kerala setting, I mean, I think 50%, nearly 50% of women are either overweight or obese, and there's no effort that's been taken to sensitize people or inform people that this is going to be a risk for during pregnancy. So I think it's a complicated thing, and I think it's important that we need to start thinking of taking the first step of engaging pregnant women in community-based trials, and the institute. I mean, depending on the prestigious nature of the institute, the kind of communication that the researchers give would be trustworthy for the community, because this institute where it was done it's a prestigious institute, and that's why it was easy to make the intervention happen. So it's kind of complicated, but these are the challenges. There is community perceptions prevailing, and we need to address it at some point in some ways. I would say that community engagement, I mean, the GDM should be, I mean, high risk for pregnancy should be communicated very well, and people should be informed. Rather than excluding. I mean, rather than excluding from the initial stage of the trial, they can be informed that these are the risks. But there is a possibility that they may attribute the complications to the trial. But I don't know whether during the morning presentation, we were talking about insurance and covering for complications if it is related to the trial. But it has to be clearly listed out in the protocol and communicated if we are undertaking a research in the community.
Thank you for those presentations. Two issues. One is, I mean, we've sort of focused on the legal quagmire. There's this whole issue around the cultural quagmire, and especially, I think so in Kerala as well. So just yesterday was a news report from Kerala where a woman who had just delivered could not breastfeed for the first 24 hours because her husband was a follower of a cleric who had decreed that until the newly born child, had heard 5 calls of prayer in that day, he could not breastfeed. So the hospital has gone all the way to file a police complaint. The woman has been interviewed. The woman said, I'm fine with breastfeeding, but I have this concern that my husband will divorce me, and hence I cannot go against his wishes. So I think that's sort of the cultural part, which is equally a challenge. So there are issues around archaic laws, there are issues around guidelines which might sometimes not be clear, and there are these issues around the cultural reality of where of the lived lives women lead. And I think all of those complicate issues in terms of decision making, especially. So we can use fancy words like emancipated minors, but in truth, is emancipation possible when you have those challenges? We could find ways of getting women who are younger than 18 into clinical trials, but then you will face these roadblocks where you have cultural issues which can be a big challenge to deal with. The other issue I want to deal with is, so I think what sometimes happens is that you can have research happening and you face these issues, but at the same time, there are programmatic interventions which focus on the same population who might be below 18. For example, now there is this big push in India to deal with malnutrition. And the whole idea that if you want to look at stunting and wasting, which is a major issue in India, you really need to look at prenatal interventions, natal interventions, and postnatal interventions, especially in the first year of life. And the only way you'll be able to deal and intervene is to actually have a strategy of for example, having looking at nutritional requirements of pregnant women or prenatal women who might also be below 18. But in that case, because it's a programmatic intervention delivered by the government, you somehow avoid these kind of quagmires because the government is introducing it. It's a national program, and hence no questions asked. Whereas if the same were to be couched as a research study, you would probably not be able to do it. And so there are certain ways of pushing interventions when we might not have evidence-based just because they are policy interventions, it becomes much more easier to introduce them. Yet at the same time, if we want to do it actually from an evaluation perspective, it becomes difficult. So I think, there are all these complexities at heart of also dealing with these issues, which are, I think, important to put on the table.
Did you want to offer a comment or just take that as a comment?
I think it's best to leave it as a comment.
Hi, I just wanted to add one more comment to your question from a practical perspective, running a trial in pregnant women, how we've dealt with that issue of concern about people falsely attributing the vaccine, in our case, as causally related to a pregnancy outcome. So we've tried to address it in 3 ways. I think 2 are relevant for the diabetes studies. One is it's so important to know the background epidemiology of certain events. It still doesn't necessarily help lay or public opinion, but I think it's very important so you can compare. And then second, the role of the Data Safety Monitoring Board. Again, may not address lay concerns, but can help. And then the third that we did was for the phase 2 and phase 3, phase 3 trial, we had very strict exclusion criteria in an attempt to minimize confounding variables which would contribute to having a spontaneous poor outcome. I think that's the harder one to do in a study with diabetic pregnant women, but perhaps one thing I could think of is like if you could say, okay, women who have diabetes could be enrolled, but not diabetes and hypertension, because then, although that's really hard because a lot of diabetics develop hypertension, but just some practical.
Actually, I understand where this is coming from, but many of the interventions, both Elizabeth and I, are talking about public health interventions. And as Anand just now pointed out, these are programs, at least in the case of the GDM, it's a government program. And many of these interventions are desirable, and they are not clinical interventions. They are not things which involve doing or intervening with a clinical product in pregnant women which can cause an adverse event of any kind. Yet, even for something as simple as this, ethics committees are reluctant to allow the engagement of pregnant women below the age of 18 for various other reasons, when they can actually, in both interventions, stand to benefit from any engagement. Leave alone going to, things where a data safety monitoring board, a community advisory board to tell us what to do, which actually we do have in many of these research, especially in Kerala. We can't do these studies without a community advisory board of some kind because we have very strong grassroots level democratic processes. So.
Hi, thanks, Irene Melamed from Flaxo, Buenos Aires. Regarding what Ignacio mentioned about that women are not included in great proportion in the labor market, I also would like to add, as in the case of Mala mentioned, that they also have a high literacy rate. And that's a good point. I think that that's a protective factor, no? And I think that perhaps it would be of interest to design some sort of matrix, for example, in order to identify some social determinants that would inform us whether there are certain contexts that are more proactive to include women in research, for example, or in ethics of research in pregnant women, and also perhaps to some IRB in order to identify whether the conditions are more proactive to do this kind of research. Thanks.
This is Dr. Hema Dumale from India. I have a comment. It is a little more contradicting. This is to Dr. Elizabeth. I feel any exclusion of pregnant women in any clinical trial should not be looked under the perspective of ethical issues or vulnerability. Because the type of trial, what we were telling about, was assessing, changing the risk of diabetes by lifestyle modification in a general population. We cannot consider pregnant women under general population because of their altered physiology, and they are special as far as the pathophysiology for diabetes mellitus is concerned during pregnancy. So if we include pregnant women in the general population, which involves males and females who are at risk to develop diabetes, finally there will be an effect on the final outcome of the variables or the results. So you could set up a similar study involving only pregnant women. There are no ethical issues. You involve only pregnant people, you do the lifestyle modifications and see what is the result of these lifestyle modifications on the effect of diabetes mellitus. So I have this type of a view where you cannot compare the pathophysiology of pregnant women who are especially at risk to develop a condition called diabetes along with the general population and then lead to a lot of variability in the final outcome of these interventions.
I would like to comment on that. This is an effectiveness trial, basically, to look into how well you can culturally adapt a lifestyle intervention program in a community to prevent incidence of diabetes. And in that case, there is strong evidence which states that women who are at high risk for developing diabetes can be prevented from gestational diabetes if 4 lifestyle risk factors are controlled. So we are not talking about pregnant women who have gestational diabetes. We are talking about women with high risk factors like abdominal obesity, low physical activity, advanced age, family history of diabetes. So these are not the physiological parameters that would actually, it actually plays those factors play a role in developing gestational diabetes. And I think it's important that they are given a choice, they are screened for high-risk status because it's a population-based effectiveness trial, and just because they are pregnant, they cannot be excluded because it's a population-based study. And especially Kerala is a state with advanced epidemiological translation for non-communicable disease, and gestational diabetes is rising. So population-based approach should be done to reduce the incidence of gestational diabetes. Gestational diabetes is not the interest of this study, but the lifestyle modification plays a role, crucial role.
But I feel the women who were pregnant at that point of time and at the time of enrollment were excluded. So you have all the other subset of women who were at risk to develop diabetes based on your diabetes score. So we can still think of a trial of a similar nature involving only only women who are pregnant, and then you do lifestyle modification and get some results. I don't think so there is ethically any issue. In fact, I feel excluding pregnant women in such a trial is scientific and justified.
Okay, so we are getting near the end of time. I've already recognized this person, but I see 2 hands that seem to be quite excited. And so I want to just ask, is it directly on this point? Because if so, then we'll continue that conversation, and the last word will go here. So if it's directly on this point, I'll recognize the 2 of you. We'll then have the last question here and move into our group discussion. So yeah, if you could give it to those 2 individuals there, thanks.
I'll be extremely brief. Marianne Kruger from South Africa. I'm a pediatrician, and I have to say that when we're dealing with pregnant women, we're really worrying about the baby and the mother. And coming back to that, whether it is at the same time scientifically correct or not, the first 1,000 days of a baby's life is crucial, starting from conception to the 2nd year of life. Nobody has spoken about it yet. What these 2 case studies have done is going to make major impact of better lives for those children. So it's unethical not to include them in such studies, regardless of how you do the science. This is unethical, and children should benefit, and especially the unborn fetus. The question was earlier, what about the baby? The baby in these particular 2 case studies will benefit.
I agree with Dr. Elizabeth. I would like to add something over here. Like ma'am said regarding lifestyle interventions, I would like to mention there is a very big yoga university. Yoga universities right now, we have 10 in number in India. We have 10 yoga universities where Indian Council of Medical Research has given a lot of grants for conducting studies, and randomized control trial was, sanctioned the grant for seeing the prevalence of the GDM. I mean, the ladies who were at very high risk, the pregnant women who were at high risk. I'm using the word high risk, not the one who are already, are diabetic. They all were included in that trial, and they all underwent yoga and pranayam therapy. And the results were really, I should say, they were very good results were there. And those of you who were given in the experimental group, then there was a control group, and those of you who were given this trial, of yoga and pranayam in the early morning sessions and also in the evening, only pranayam in the morning and yoga in the morning and evening, they had significantly reduced incidences of GDM. So I think lifestyle modifications, if given to people, the women on risk, would be certainly highly advantageous and also reduce in the morbidity and mortality. And plus also over here, if we look about not only the four, I think the risk factors which you have mentioned, the 4 lifestyle factors, yoga and pranayam, lot of research is being conducted not only by Patanjali, that is by Baba Ramdev, the global guru of yoga, who has made yoga on the world map, or on the world medical tourism map of the world. But it has significantly reduced mortality as well as morbidity among the RCH group. That's what I would like to add with Dr. Elizabeth. Thank you.
The final word from me. Yeah, so my comment is to do with the issue of adverse events. So adverse events, if they are not handled properly, they can actually destroy your study efforts. But it's very, very important here to realize that in addressing adverse events, there are also other entities like the ethics committees and also the national drug regulatory authorities that can actually do causality assessment, because they're actually independent from your trial, and they can actually assist in actually bringing out an independent judgment concerning an adverse event. So a very, very important bit is about community engagement, as has been emphasized from before, and also issues about communicating openly about those adverse events. Thank you.